They wash off. There's not a Sharpie.
Okay. Sorry.
No,
I'm no.
Hold on one second. I'm just gonna get my phone. I can take a picture of that for us. Okay. So you're right. That's why I'm not scheduled. Sorry, we were just looking at my my operating room access. We're doing a bunch of things out here. I'm gonna pull up your CT scan. We'll look at that together, and we'll talk about what the next step is. You know, we can fix it. So long story short, the issue is that it's gonna be kind of hard, but we'll give it a shot. Well, at least
worse than the first time.
We'll tell you all the risks and benefits. You get to make the choice, obviously. But so I'm gonna just put this here. Take a picture.
Oh, is that for size reference?
Yes.
Okay.
I couldn't find a ruler in there, so
Gotcha.
use the
Oh yeah. Hey, it's a MacGyver thing.
That's right. That's right.
Yeah.
Only needs the numbers.
Yeah. So you'll explain what you meant by hard.
I will.
Okay.
Yep. Absolutely. Yeah, actually, it'll help when we look at the CT scan together and go over. Have you ever tried an abdominal binder?
Yeah, I wear one.
Oh, okay, good. So you have one at home. You
Yeah,
have
I
one.
have this compression shirt that
Okay.
I wear
Okay.
every single day.
Okay.
Am I good?
Yeah. Does a binder help you?
You know, it's kind of long for me, but yeah, it does help if I've got a cough or a cold. Kind of helps.
Did you get one from us? Do you want one? We'll give you
Sure.
one.
Would be a better one?
Sure.
Yeah. Awesome.
We'll give it a shot.
Yeah, awesome.
Hey, is basically it's a hole in one of the layers of the abdominal, one of the inner layers of the abdominal wall, and you can feel it. That's what I was feeling the edges of and marking with a pen just to size it in correlation with the CT scan. So what I'm feeling is the size of the hole in the inner layer of the abdominal wall. Thank you very much.
Awesome.
You can try that at home.
Thank you.
And essentially, what we have to do is get that hole somehow closed.
Close. Because on the inside it's open, right?
Correct. And your skin obviously is still intact. You have a little thin layer of subcutaneous fat still there. Even your what's called a peritoneum, which is this on the layer on the inside. It's not a strength layer, but it's a layer on the inside of the abdomen. That's intact too. So if you imagine, for simplicity's sake, you have 4 layers of the abdominal wall: skin, subcutaneous fat, fascia, and then the peritoneum. So it kind of meets in the middle like this. Your fascial layer has a hole in it, both sides, like that. So if you were to look at we look at you this way. So you're laying on your feet. So the peritoneum, this is stretchy. Okay, the fascia is what's actually the strength layer. So what happens is that this bulge kind of comes out. This peritoneum stretches like this, and what I'm feeling for is the edges of the fascia that are kind of like retracted out now. And you can see that on the CT scan. So this is you laying. Your back is here. Your feet are towards us. Your head's on the other side of the monitor. Okay, you're laying. It's not like we're looking at slices, X-rays of you like a bologna. Okay, so this is the edges that I'm feeling with your fingers when I'm pushing it. I know you're uncomfortable. I'm sorry for that, but this layer is what I'm talking about. That's the peritoneal layer. This one that's stretchy, and then this is your subcutaneous fat. That's this layer, and this skin. So this has, this should be together in the middle like this, and everything that's on this side of this line should be on this side of the line, if that makes sense. And then you don't have as much of a bulge. This is all intestine. This is air.
Oh.
So your intestine, which normally sits inside the abdominal cavity. That's right. And maybe sometimes when your skin's that thin, if you really like watch it and look, if you really want to kind of gross yourself out, you can see the intestine contracting underneath the skin there.
Well, I know that part, but
When she coughed
it.
just now, it looked like alien was going to come out.
Yes,
Yeah.
that's partially, you have
Yeah.
it's a partial diastasis, partial hernia. So the diastasis, what a diastasis is, if you saw that language in your CT scan and then Googled it, the diastasis is a stretching of normal tissue. So basically, there's no hole per se. It's just you've taken the tissue that's normally there, stretched it out. So now there's like a little bit of a bulge. It's not a true hernia, it's a diastasis. Most common in pregnant women or after they've delivered their baby. Things get stretched out and don't always return back to normal, right?
Yeah.
So, you have kind of a component of both, but this is, we can fix, yours is fixable because you have some degree of a hernia. Now,
Thank you.
when I say hard, it's because the distance between this edge right here and this edge right here is far. And so we have to pull it together and close it, and with enough strength that when you cough, you're not going to just rip it all open again.
Okay.
And that is a risk no matter what we do, no matter how we fix this.
Mm-hmm.
We don't have cement, so we do our best to sew your tissue back together. We use some degree of mesh, inevitably.
Mm-hmm.
So
this is going to be my friend.
correct.
Okay.
So some degree of mesh to help buttress the repair that we do. But all in all, it is going to require a fairly long operation and a risk, frankly, that it comes back. Oh yeah, you would be asleep. It's going to be about 6-8 hours.
Oh, really?
Yeah, and the risk?
Risks. Okay, so risks are we injure the intestine on the inside because all this stuff looks, like I said, you asked what that is. Everything is stuck in all likelihood. Everything is not just, you take this off of it. Everything is going to be stuck to one another. So there's a risk that while we're trying to free everything up, we injure the intestine. That's the biggest risk with these operations. Sometimes we can see it right away. Then we fix it. Sometimes we don't see it right away, and then it'll leak inside your belly when we're done with surgery, and that's the worrisome issue.
That's septic shock time.
Correct.
Yeah.
You can develop what's called a
had
sepsis,
this
or
2
you
years
can
ago.
develop a fistula,
Yeah.
where you start to. Have you ever had a fistula? Where you start to your intestine will communicate with the skin, and it'll start to your intestinal contents will leak out of your skin into your abdominal wall. That's the biggest problem because those are really hard to treat. They take a really long time to go away. So that's the main sort of feared complication of these kinds of operations. Anytime we are operating around a lot of scar tissue in the intestine for an elaborate hernia repair, the two biggest risks for us are intestinal injury. That's the one that would, keep you in the hospital, make you sick, potentially be life-threatening. And then the second one is recurrence. So even after we put you through the hospitalization, everything goes fine with the surgery, then if something rips, the hernia comes back. Usually that's not life-threatening, but then it kind of is, it's really defeating.
Kind of awesome.
Yeah, it's defeating for both of us because you have your symptoms recur, and we've gone through all this whole thing, and now, and every time you have to fix a hernia with subsequent surgery, it's harder than the one before it. So it doesn't get easier; it gets harder. So that's the uphill climb that we have to face. Sometimes we just don't face it for some people, and if it's too steep of an incline, and we say it's not worth the risk, we don't do it. In your situation, as long as you are aware of the possibilities, it's not going to be an easy surgery. It's not going to be free of risk for complications, then we can try.
Well, I knew that.
Yeah.
All hernias have a risk of reoccurrence.
Right.
I knew that.
Yeah.
So, no, this has got to go.
Yeah.
It's causing me to stumble and not my friend. So
Gotcha.
how long is recovery time?
So you'll be in the hospital maybe about a week, maybe a little bit less.
Okay.
And most of that's for pain control. Make sure we don't have the issue where we've injured your intestine, kind of steer clear of the complications. When we go in and we manipulate the intestine to get it off the abdominal wall so we can free this stuff up and close it.
You have to just cut some of that out?
No,
Room?
no.
don't want to do
No, we want to leave all the intestine that we can. But sometimes when we even manipulate it, not necessarily injuring it, but touching it and dissecting it free from its scar tissue attachments, the intestine kind of goes to sleep a little bit. So after surgery, sometimes it can take a while for the computer to reboot and your intestines to start propelling things from mouth to your bottom the way that it should be.
that. Oh,
Right.
poopy?
Yeah.
Correct.
You're the first
So
to
sometimes
tell.
the intestines don't move
Yeah.
in the correct direction all the time. It's kind of like a tube of toothpaste. You know how
Yeah.
you roll it from one end to the next, and so it comes out the end. That's how you want to get toothpaste out. But if
Right.
you imagine taking the tube of toothpaste and squeezing it on both ends in an uncoordinated fashion,
Right.
the toothpaste doesn't really come out effectively. The same
Right.
thing. We like the intestine needs to move in one
Contiguous.
direction,
Yeah.
not back and forth. And so sometimes when after this operation, it takes a little while for the intestines to figure out
Yeah.
how to do that again.
They forget.
So that's why essentially those are the things that we look for while you're in the hospital after surgery. Are you working?
No, I'm retired.
Okay. So I don't have to worry about time off work talking about that. But we talked about the risk of injury to the intestine. The other risks, bleeding. Any surgery we do. This is not a high bleeding risk operation, but it's a risk nonetheless. Infection. So anytime we go in there, we remove things, we shift things around, we put mesh in the belly, there's a chance that gets infected. If that gets infected, it can be a big deal. We gotta go back in and remove everything, and then we're back to square, probably even below
Further back.
square, further
Yeah,
back than
negative.
square one. So that can happen. It's not high risk, but it's a risk. Are you still smoking?
Yes.
Yeah, that increases
7
your
or 8
risk.
a day.
He's
No,
waiting
I'm
for
quitting.
you
I've
to
got the
tell-
patches and I've
He's
got-
waiting for you to tell her she has to
Yeah.
right now.
I
Yeah.
mean, if I could forecast to you a future where we go into surgery, we put in a piece of mesh and it gets infected, you would rather die. So the way to decrease your risk of developing all that
Put that down.
is stop smoking, because that's the biggest risk you got for
She's
getting
got her
infection.
Nicorette, she's got her patches. She just got them in favor yesterday.
Yeah,
I'm her ex-husband, I'm taking care of her right now.
gotcha.
Okay,
Gotcha.
but at the same time, it's hard for me not to just go, eh.
Yeah, gotcha,
But,
gotcha.
But yeah, because I don't want to push, because you have to decide on your own. I know how it is. I used to
Yep.
smoke, so.
Yeah,
So how far out were you from surgery, from scheduling this?
couple months.
Couple of months?
Because of the cigarettes mostly, and also
No.
your availability.
Yeah,
Okay.
I
that.
don't tell them that. So
Yeah.
some more ammo.
Oh, I see. I see. Yeah, it's because of the smoking. Well, actually, no, it'll give you
Yeah.
a good time to
6
quit.
weeks.
No one quits right away.
Right.
So that is the single most alarming risk factor for infection of the mesh is active smoking. Some surgeons, he's right. Some surgeons won't do it if you're smoking.
Right.
But
But you let her know the risks. It could
Yeah.
kill her. Essentially, it could. Not
it's a
indirectly.
miserable existence to have a fistula and a mesh infection. So the single thing that you can do to decrease that risk would be quitting smoking. It'll help me too, because I don't like it on my conscience to give you a mesh infection or a fistula.
Yeah.
So I
I
don't
understand.
need to quit smoking. Okay, enough said about that. What other questions do you have for me? I think I've said everything I need
I
to say.
have questions on what can I lift, when can I walk, when can I,
After surgery or now?
after surgery.
Usually I will ask you not to lift anything greater than about 20 to 30 pounds. So, gallon jug of milk in each arm for about 3 weeks.
Okay.
Yeah, but walking,
doable.
fine. You walk
Okay.
as soon as we'll get you walking
Because
the
I'll be
day
in the
of surgery
process
the
of
next day.
moving it, here pretty soon about a house, so
Oh, good.
I want to get in
Congratulations.
there and get settled.
Yeah, up until the time of surgery, no restrictions.
Okay.
Whatever your comfort level, you're not going to make things worse.
Okay.
But after surgery, the reason why you have restrictions is that so you don't
Redo it. Yeah.
rip the repair. That's it.
Okay.
So did she get put on a list, a wait list at this point? Or?
She can, but given how long your surgery is, the chance that they'd be able to squeeze you in to a cancellation
That's
spot
kinda
is
hard
low.
squeeze.
No, I just mean there's a
There's
schedule.
a standard wait list. Yeah. So
Yeah.
what I'm going to do, I'm going to go back to my office, put in the request for surgery. My medical assistant is going to come in and talk to you about something enhanced recovery after surgery. It's just a video you got to watch, and then you get on the phone with the surgery scheduler. In all likelihood, she'll tell you, I don't have a surgery date available for you yet. I'll call you when one becomes available. That usually means 2 to 3 months.
Okay.
Okay.
Okay. Thank you very much.
Awesome.
Appreciate your time.
Sure. Good to meet you.